Welcome, everyone. Welcome to this webinar on understanding RSV in older adults, the burden of disease and risk factors for severe illness. I'm Joseph Miller. I'm an emergency physician with Henry Ford Health and clinical associate professor of emergency medicine, and have had a significant interest in respiratory diseases, including RSV, ever since the pandemic, and particularly its impact on adults and the intersection with other comorbid conditions. And with me, we have first Amanda Stolars. Amanda, would you like to introduce yourself?
Hi, yes, I'm a PharmD and PhD here at the University of Arkansas for Medical Sciences. I work as an assistant professor in the College of Pharmacy. And as a pharmacist, we're always interested in how we can support the vaccination efforts and immunization efforts for all of our preventable diseases.
Great. Next, we have Amy Braddock, who's joining us. Amy, please give an intro.
Yeah, hi. I'm Dr. Amy Braddock. I'm a family medicine physician at the University of Missouri in Columbia, and I care for patients both in the inpatient and outpatient setting. So I have a lot of experience with the disease burden of RSV, and I'm just very excited to talk about RSV vaccines in older adults. Thank you for joining us.
Thanks, Amy and Amanda. And this is the first webinar in a two-part series that our group is putting on through the American Heart Association that addresses RSV immunization recommendations for older adults. As a disclaimer, the series is made possible through an educational grant from Pfizer, but it's important to note recommendations and opinions presented may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device. So after the presentation, we'll have a Q&A session to answer your questions, and we should have ample time to do so. So please type in your questions in the Q&A section on your screen whenever you see fit, and we will answer them as time permits at the end. And so with that, we'll get started. And first, we do want to bring up faculty disclosures, which are listed below. And we have two learning objectives for today. So first, we hope that you all will recognize the RSV burden of disease in adults that'll allow you to better discuss the potential benefits of RSV prevention with patients that you care for. And second, we'll identify chronic medical conditions and risk factors associated with increased risk of severe RSV disease, meaning RSV disease that's severe enough to warrant potential hospitalization or prolonged symptoms in patients we all care for. So with that, I'm going to turn the slides over to Amy, who's going to talk with everyone about RSV.
Thank you, Dr. Miller. So probably most of you are familiar with the respiratory syncytial virus, or RSV. It is an enveloped virus in the genus pneumovirus and the family Paramyxoviridae. And as probably most of you know, it causes respiratory illness really in a wide variety of age groups. But there's really two age groups that has the biggest disease burden that we worry the most about. The first one, obviously, being it's a common cause of childhood illness. In fact, the most common cause of hospitalization in infants. So much so when I was a resident and medical student in my pediatric rotations, kind of the end of fall, beginning of winter, we called that the RSV season because there was so much hospitalizations of infants during that time. But there's another group of patients that are actually very much affected by RSV as well. It causes severe disease, hospitalizations, and even death, and that's older adults. And there's really certain chronic medical conditions that really increase these patients' risk for hospitalization and death. So this is the group that we're going to really focus on today, and really understand who's most at risk and who do we really need to be focusing on with this vaccination. It can be pretty disheartening being a healthcare provider. There's a lot of vaccine hesitancy out there and social media posts, but really the evidence suggests that healthcare providers are one of the most important factors that influence a patient's choice to accept a new prevention product or vaccine. So even though it can be frustrating and feel like we don't make a big impact, we actually do. It actually is really important to talk about these vaccines with patients. We know that there's a seasonality to RSV outbreaks and that the risk increases with age. So there's two subtypes. There's an A and B subtype of the RNA RSV virus, and the onset is usually kind of mid to late fall, mid-September to mid-November, and then we see the peak late December, mid-February, so kind of mid to late winter, and then the offset usually in the spring, mid-April to mid-May, around there. Then we get a couple months and we start the cycle all over again. So it can be kind of a wide-ranging season. And in general, we know the disease burden of RSV is pretty significant. So 2 million outpatient visits in children under the age of 5, but over 65 also very significant. In general, 177,000 hospitalizations in adults, and then 14,000 deaths in adults over the age of 65. So definitely a disease we should be thinking about. And it can be pretty hard to pin down exact numbers because it's kind of a moving target, but we were able to find this recent data from the CDC. So this was from October 1st of 2024 through April 12th of 2025. And during that time, there were an estimated 3.5 to 6.5 million RSV outpatient visits. So this is taking up a lot of time in our clinics. Pretty wide range there, but regardless, still very high numbers. And then of those, 180,000 to 340,000 RSV hospitalizations estimated during that time. So not only a big outpatient burden, but a big inpatient burden as well. And then most significantly, it does have a high mortality and death burden of 10,000 to 22,000 RSV associated deaths during that time. So this is really why we're most concerned about that. We have a tool to help prevent deaths in our elderly population. So that's why we feel passionate about talking about this. I really like this graph because it overlays the RSV numbers over different years. So we can see when they had significant rises and outbreaks. So you can see kind of starting 2018, 2019, moderately high, fairly high in 2019, 2020, actually went down significantly in 2020 to 2021, a little bit higher in 2021 to 2022. There was a lot of COVID precautions still happening, and that really helped suppress RSV as well. But we did see a pretty significant increase in 2022 to 2023 when those restrictions really were lifted and people were interacting a lot more. I don't know if you remember 2022 to 2023, but it really put a pretty big strain on our hospitals and ER just with the outbreak of RSV and other respiratory viruses as well. We also know that we spend a lot of time talking about influenza vaccinations and the disease burden of this. And that's important because we do know that influenza has a big burden and health impact. But compared to RSV, RSV is actually pretty significant as well. So if you kind of look at the numbers back to back, 1.05 million influenza outpatient visits. It's actually a little bit higher for RSV, that 1.4 million. Slightly fewer hospitalizations, we believe 159,000 per year compared to that 171 of influenza. But actually, that 6 to 8% case mortality, pretty high for RSV. So 9,500 to 12,000 deaths per year for influenza compared to about 16,000 deaths for, or excuse me, the 9,500 to 12,700 for RSV, and then the 16,000 for influenza. So once again, very high mortality disease burden really for both of these, and they both deserve our attention. And we know that the risk is not the same for everyone, that as patients age, the risk of RSV increases. In adults over 60, there's an estimated 700,000 to 2 million cases annually. So it really seems to affect older patients more than younger patients outside of that kind of neonate less than 5 age group. And we also know that there's higher rates of mortality above the age of 65. So an estimated 78 to 82% of all RSV-associated deaths did happen in that older age group over 65, with that 6 to 8% mortality that I mentioned. So this is why when we talk about the CDC recommendations, it really kind of hones in this older population. And we also know that there's long-lasting consequences of these RSV infections. Actually, the 1-year survival after admission is lower in older adults hospitalized with RSV compared to influenza. So there seems to be something about this virus that has a higher morbidity, higher mortality in the long run compared to influenza. And probably a lot of you are familiar with the clinical manifestations of RSV. Fortunately, most of the time it's going to prevent with mild URI symptoms. So most patients may not even know that they've had an RSV infection. Most of the time it just presents with runny nose, congestion, decreased appetite, maybe sneezing, but it's when you get more of the lower respiratory symptoms that we start to get more concerned. So the coughing, fever, wheezing, shortness of breath, those can be a signs of more concerning infections. And it's really when patients who have risk that develop the acute respiratory symptoms that we really start to get concerned. So if we're worried about pneumonia or exacerbation of respiratory conditions such as COPD or asthma, that's when we start to think about, does this patient need to be in the hospital? It's usually the hypoxia that buys them that admission. So when their O2 sats start dropping and they require oxygen is when they're usually hospitalized. And that's an estimated 11.9% of those patients. And then that potentially fatal case fatality of about 6 to 8%. Now we're going to watch a patient video from a real RSV patient. This is John Teagarden, and he's going to talk about his experiences having RSV.
I understand that recently you were in the hospital with respiratory syncytial virus. So can you tell us a little bit about your background, medical history, any underlying medical conditions that you have?
I do have some COPD, but beyond that, no particular issues.
All right. And does it tend to bother you, or are you fairly active?
I'm fairly active.
Okay. And I see you're wearing oxygen now. Had you been wearing oxygen prior to this illness?
No. When I went into the hospital with the RSV, they prescribed oxygen, and it has continued as I've come home. I just woke up unable to breathe. Got on a albuterol mist, and that quieted it down some, but I said, take me to the hospital. The RSV was the worst.
Okay.
I mean, it closed me right up as far as breathing.
Mm-hmm. And how's your strength and your just general?
Oh, I don't think there's any question that I'm weaker. I definitely have lost weight. I'm probably down 7, 8 pounds since the onset of this.
I would say that is fairly typical of what we see in patients that, especially once they're hospitalized and requiring oxygen for RSV, it just takes them a long time to recover, and unfortunately, some never actually recover. I wanted to talk a little bit about some of the differences and similarities of some of the common respiratory infections that we see, because we got pretty good about differentiating COVID versus flu versus RSV, but it can be pretty challenging, especially in the outpatient setting, diagnosing these. We have pretty good tests for COVID and flu with the rapid swabs, but the RSV tests, those tend to be more expensive and take longer. So using symptomology can sometimes help, but patients also present atypically. So I find this to be really challenging with my outpatient clinic patients. In general, COVID, we think of more the cough, fever, chills, sometimes some of the upper respiratory symptoms, but really more of like the cough, difficulty breathing, and then the loss of taste or smell, remember, is fairly pathognomonic for COVID. Contrast that to the flu, also can present similarly with the cough, sore throat, fever. These patients tend to have that kind of been hit by a brick wall, just myalgias, fatigue, but can also present with headaches, nausea, and vomiting. Whereas with RSV, I usually think of these patients more when they've been having kind of the upper respiratory symptoms, congestion, runny nose. As I mentioned, it can be more of the lower respiratory with the cough, fever, wheezing, but usually we think of kind of the upper respiratory symptomology. And then if there's kind of one slide that I want you to take home, it's this one. This is the CDC recommendation for RSV vaccines. So the recommendation right now, this could change in the future, but right now, all adults over the age of 75, there's a recommended 1 dose of the RSV vaccination recommended. Regardless of your risk factor, everybody over 75 should get 1 dose of RSV vaccine. Adults 60 to 74. Now, this changed in June of 2024. Before, it was kind of everybody over the age of 60. Now the recommendation is 60 to 74. They should also receive 1 dose of RSV vaccine if they have risk factors. And you may ask which risk factors included in these patients. So really any chronic medical condition that's going to increase their risk for RSV. So chronic heart disease or lung disease, diabetes with complications, immunocompromised state, or just other risk factors. And we'll talk about some of those other risk factors here in just a little bit. The other population that really needs to be vaccinated in this age range are long-term facility residents. And that's really just because not only do they tend to have more chronic risk factors and more comorbidities, but also they're in closer proximity to each other, so they're more likely to be exposed and get the RSV virus. So that's why this group is included as well. All right, now I'm going to turn it over to Dr. Miller, who is going to talk about conditions that increase the risk for severe RSV.
All right, thanks, Amy. So we've touched on some of these already, but I'll go through kind of the extensive list and describe some of the data behind what we know about, how to quantify the risk of different conditions that older adults have. And a lot of them are overlap too substantially with what we see with flu and COVID in terms of comorbid conditions that put patients at higher risk of hospitalization or severe disease. So by system, first is chronic cardiovascular disease, and this includes heart failure, coronary artery disease, congenital heart disease, and even isolated hypertension. Respiratory, certainly we saw this highlighted in the patient story that we saw, which the gentleman, Mr. Teagar, had COPD. And so chronic lung diseases such as COPD or emphysema, asthma, interstitial lung disease, cystic fibrosis are all risk factors. Patients who have end-stage renal disease and on hemodialysis or other forms of renal replacement therapy are at higher risk. And patients with diabetes, especially those have diabetes with complications such as chronic kidney disease or neuropathy, retinopathy, or other end organ damage. And patients with diabetes who are taking insulin or SGLT2 inhibitors are at higher risk. Next, patients with neurologic or neuromuscular conditions are at risk. Many of these conditions can impair airway clearance and also contribute to respiratory muscle weakness, putting patients at higher risk of respiratory complications from RSV. These could include patients with dysphagia after stroke, as well as those with ALS or muscular dystrophies. There's others. Chronic liver disease can contribute to impaired immunity and higher risk for RSV. There are chronic hematological conditions that also put patients at risk, such as sickle cell disease or thalassemias. Severe obesity, particularly those with body mass index over 40, can have higher risk. And then those with moderate to severe immune compromise, whether that be patients on organ transplant or on immunomodulatory therapies for cancer or other conditions. And then there are, this is fairly comprehensive list, but there are other conditions that you as a clinician may deem your patient to potentially be at higher risk that may be unique to that specific patient. And essentially anything that either compromises pulmonary function, compromises cardiovascular function, or compromises immune response can all contribute to worsening outcomes in RSV. So the CDC has identified these particular subgroups, many of which we just discussed. Again, particularly your COPD and asthma, patients with heart failure or coronary disease, diabetes mellitus, particularly with complications, neurological conditions that cause muscle weakness or dysphagia, and then kidney, liver, hematologic disorders, which often are associated with some degree of reduced immune response. Patients on immunosuppressant medications or who otherwise have reasons for immune compromise. And then this is all in the context of having advanced age. And then, as Amanda mentioned, particularly patients that are residents in long-term care facilities are at high risk, both because of their proximity to other patients with comorbid conditions and because they themselves often have quite a few comorbid conditions that led them to need long-term care. So central to these risks is the role of waning immunity in patients. And this ties in, you'll see, fairly well when we look at older adults and the current CDC recommendations. So RSV, as Amanda mentioned, often starts as RSV bronchiolitis or post-bronchiolitic wheezing from infancy into childhood. And then RSV can cause cold-like symptoms or may exacerbate patients' underlying asthma or COPD into adulthood, or simply lead to colds that patients experience. But as adults get into the 70s particular, there is a decline in innate immunity and immune response, such that the ability to fight off RSV infections, as well as other viral illnesses, wanes. And as much as I love to think that we all would remain invincible for all of our lives, eventually we all lose some degree of immunity. So what we see is that, you know, the risk really goes up substantially with these other comorbidities. So RSV with acute respiratory infection in patients that have comorbidities affects about 37 per 1,000 person years. But with without comorbidities, that rate is about a fifth of what it is with comorbidities, only affecting about 6.7 per 1,000 person years. And so this data, fairly clearly shows that comorbidities plus RSV in older adults really substantially increases the chance of severe illness. Here's a breakdown of particularly who we see in the data of among hospitalized adults with RSV, what comorbidities are particularly associated with that. So as you can see, COPD is a substantial contributor to hospitalizations with RSV. These patients often have chronic inflammation, airway remodeling, and data shows that they will have higher RSV viral loads if you sample their bronchial secretions and have prolonged shedding of the virus. They can actually have up to about 13 times higher rates of hospitalization compared to individuals without COPD. Asthma also, we see this in young children and young adults that RSV can frequently contribute to asthma exacerbations. But as in patients with asthma who are older and over the age of 60, they can have up to 8 times higher rates of hospitalization compared to those without asthma who have RSV. And then RSV can also exacerbate underlying heart failure, and often the combination of RSV and worsening heart failure with pulmonary congestion is a common reason for hospitalization. And as we see with flu, you can have exacerbation of underlying coronary disease and even type 1 or type 2 myocardial infarction in the setting of RSV and hospitalization. Here's some data on long-term care facility residents, again showing substantial increases in hospitalizations among this cohort. So for community dwelling adults over the age of 65, data shows that they have kind of an underlying rate of hospitalization of about 117 per 100,000 patients, whereas skilled nursing facility patients who have RSV have a rate nearly 4 times that amount for hospitalization. And then patients that require assisted living also have much higher rates of hospitalization related to RSV compared to community dwelling adults. So if you look at all the patients over the age of 60 hospitalized with RSV, approximately 17% are long-term care facility residents. So again, we know age is a major risk factor for waning immunity. And then if you add to age, advanced age, chronic medical conditions such as heart disease, lung disease, diabetes, and immunocompromised states, the risk for hospitalization goes up. And then particularly with long-term care facility residents, they are at significant risk of hospitalization if they have acute RSV. Okay, with that, I'm going to turn it over to Amanda, who is going to continue discussing immunization recommendations.
Thank you, Joseph. So, as previously mentioned by Amy, the current recommendations by the CDC are that it's just for a single dose of the RSV vaccine for any adult over the age of 75, and all adults age 60 to 75 who are at an increased risk of severe RSV disease. And that goes back to the disease burden that we talked about and those risk factors that were just covered for this patient population. So that's why they focused on this patient population is because they can see the greatest benefit from the RSV vaccine. So when you're thinking about, okay, we're going to give them a vaccine, when should we give this vaccine? When's it going to be the most effective during the year? So as kind of mentioned earlier, there is an RSV season that generally happens during the late fall and winter season. Actually, kind of pre-COVID, we saw the peak of RSV season happening in December and January. And then during COVID, because we had all of these preventative measures in place for preventing spread of disease, we saw that peak season actually kind of shift. It decreased and it shifted over into the later spring. And then now that we've, past COVID and in these 2023, 2024 seasons, we've started to shift back to our peak season being in December and January again. And we'll see if that continues to hold through the next season as well. So really, the recommendations for when to give the vaccine, you can give it any time of the year, but the most effective would be in late summer or early fall before we get to this peak RSV season, so that they already have their immunity and protection on board before we start to see this higher disease burden. So in the United States, that's generally going to be during the months of August to October, will be when we're going to be recommending to give the RSV vaccine. So far, we know that the immunity lasts for up to 2 years from a single vaccination, and that's because these vaccines are pretty new, and they've really only been approved for either 1 or 2 years. So that's all the data we have so far to know how long the immunity lasts, and they'll keep assessing that as the seasons go on to see how long that immunity lasts. But for now, that's why the recommendation is for only 1 vaccine and not an annual vaccine like we see with others like the influenza. So another common question that may come up either by the patient or you yourself may have this question is, can you co-administer the RSV vaccine with other vaccines? So most commonly, right, the seasons between RSV, influenza, and COVID kind of coincide. So they're going to want to ask, right, going to want to know if we can co-administer these vaccines together. And the answer is yes. We can co-administer the RSV vaccine with other vaccines. Typically either influenza or COVID you may give together as well. There's some very, very limited data that suggests that if you co-administer the RSV vaccine with other respiratory vaccines, it may lower the antibody titer. But there's really no known clinical significance of this. So more data is needed. So for now, we don't see that there's any reason to not administer them together. There is a risk that you may see an increase in common side effects if you co-administer the RSV vaccine with other vaccines as well. And we'll go over side effects in the next few slides. So in general, simultaneous administration of vaccines is likely the best option for most patients. And there's a couple of questions that you should consider when thinking about co-administration of these vaccines. And first is your patient recommended other vaccines? Are they in a risk group or a patient population that is recommended to give another vaccine at this similar time? Also, how feasible is it for the patient to return for a second visit? So if they don't get them together at the same time, are they going to be able to return to the clinic to get the second vaccine that they're recommended? So some patients may have transportation issues. They may have work issues or scheduling issues. So that's why sometimes it's going to be the best option to give it at the same time, just to make sure that they're able to get both the vaccines that they're recommended. You can also take into consideration the risk for these patients of acquiring the preventable disease if they're in a situation where they're at a high risk for getting multiple communicable diseases at the same time. Then co-administration may be the best option. Also, you should consider the reactogenicity profiles of the vaccines, because again, you do have that risk of increasing the side effects of the vaccines when you co-administer them. So you may have patients who don't want to get them at the same time because they don't want to have that increased side effect. They don't want to have more headache or chills or muscle weakness. And so they want to spread it out. So making sure you acknowledge the patient's preferences on how they want to receive their vaccines is important as well. Some other clinical considerations and patient counseling to think about. So we do have 3 RSV vaccines available. 2 of them are protein antigen vaccines, and they are designed and targeted against the antigen, the protein RSV pre-F3. It's a pre-fusion protein in the RSV virus. These vaccines also have an adjuvant. Both of these vaccines were approved in 2023. Again, so why we have such limited data on our immunogenicity and long-term immune profile with these vaccines is they're pretty new. We do have a third vaccine that was approved just this December, so December 2024. This is an mRNA encoding vaccine. And again, it's also directed against this pre-fusion F glycoprotein that's in the RSV virus. So again, we have more data for protein antigen versus mRNA because that mRNA vaccine was just approved. But in general, these vaccines are very effective at preventing RSV infection and hospitalizations and ER visits. So taken together over here in this chart, the first season after receiving any of these vaccines, they were about 70 to 80% effective in preventing RSV infection. And that carried over into our emergency room visits. So this green bar is the average, and then there's a slight difference between some of the vaccines and the effectiveness, but it's not significant. So again, 70 to 80% effective in preventing ER visits due to RSV. And then also we saw that carry over in hospitalization rates as well. So these vaccines were able to prevent RSV hospitalizations. So just to kind of translate that over into numbers that might make sense to you as a healthcare provider, that you would need to administer between 1,600 to 1,800 RSV vaccines to prevent 1 RSV-related death. And 233 to 261 RSV vaccines prevents 1 hospitalization in adults over 75. So those kind of vaccination rates are saving lives in the population. And right now, we don't know these numbers for the mRNA vaccine, again, just because it's newly approved, and so we haven't had long enough to study. So coming back to the side effects of this vaccine, which you have those common side effects associated with vaccination in general, with the injection site pain reaction. You can also develop a headache or fatigue, so they can become tired or sleepy, and that muscle pain. Generally, you get muscle pain around the injection site as well. Now, the protein antigen vaccines do carry a small risk of Guillain-Barré syndrome. And just to remind you that Guillain-Barré is that rare neurological disorder in which the body's immune system starts attacking the nerve cells. And so this often starts as like tingling and muscle weakness in the arms or legs, and it can sometimes lead all the way to paralysis that results in hospitalization needing supportive care. So this is a small risk for this from Guillain-Barré syndrome, but it's a significant side effect if it occurs. So the other important thing to note is that the insurance companies are not required to cover the cost of vaccines if they are administered outside of the CDC guidelines. So this is something to take into consideration when you're thinking about recommending an RSV vaccine to a patient. Like, are they within the patient population that the CDC is recommending this vaccine for? Because the out-of-pocket cost for the RSV vaccine can range from $300 to $500 if the insurance doesn't cover it. So that's a significant cost for a patient if they're not in one of these risk categories. So just take that into consideration when making your recommendations for these patients. But in general, remember, as we've mentioned before, a strong recommendation from a healthcare provider makes a big difference in whether a patient will go through with getting a vaccine, especially the RSV vaccine. And right now, in most states, a prescription is not required for getting the RSV vaccine. And so it makes access to these vaccines easier for patients as well. So in conclusion, the RSV is a very prevalent disease that has a very high morbidity and mortality for older adults. RSV vaccines are very safe and effective, and they're a good way to reduce the risk and transmission of RSV in adults over the age of 75 or 60 to 74 with risk factors. We will have a second webinar. Please join us on July 14th, where we're going to discuss strategies to increase RSV vaccination rates to increase the protection for this high-risk population group. Now, if you'll stay tuned, we have a Q&A session that's going to be moderated by Dr. Miller, and I'm going to turn it back over to him.
All right. Thanks, Amanda. We have a lot of great questions, so we'll get started and hopefully get through most of them. First, there's a question about one of the participants thought that the CDC had dropped the age to 50 for a person with high risk factors to be vaccinated. Can we comment about the eligibility in that 50 to 60 age range? Amanda, do you want to go ahead, Amanda?
I'll let. As far as I know, there isn't a recommendation under the age of 60. And as Amanda mentioned, you kind of run into the risk of not being covered by insurance under that age range. If I have patients that come to me that want it under 60, or if they don't have those risk factors, I usually encourage them to check with their insurance. And then if either it's covered or they're willing to pay out of pocket, the risk of administering it in this population is relatively low. So, and there may be some benefits, but just know that you're outside of the CDC recommendations at that point. So there may be a cost burden associated with that. And then as kind of similarly for the long-term care, it makes sense that once again, they're at increased risk for exposure and transmission and having risk factors. So if they're under 60 and want the vaccine and know that they might be on the hook for the bill for it, I would be okay with them getting vaccinated, but they just need to be aware of the potential expense.
Good, yeah, and I think it's an area that the CDC will continue to evaluate the potential for harm versus benefit in that patient group. But great points, Amy. I think on the next question has to do with what differentiates the flu vaccine from the RSV vaccine. I thought maybe Amanda, this might be best for you to take on.
Yeah, sure. So, in general, the flu vaccine is a protein antigen vaccine as well. So similar to the protein antigens we have for the RSV, it's just going after a specific protein to the influenza vaccine. So most commonly, it's going to go after neuraminidase or another protein associated that's specific to the influenza virus, compared to the RSV vaccine, which is going after a protein that's specific to the RSV vaccine when I say it's a targeting against it so that your body creates antibodies that will target that protein and recognize that specific virus and fight it off. So
Great. Thanks, Amanda. We also have a question on, certainly in pediatrics, we've always done nasal swabs for RSV, but what's differentiated? Why are we all concerned about adults all of a sudden, and why what's different in how we're testing adults for RSV? Open it up.
That's a great question. I think it has to do both with the increased rates that we saw after COVID when I pointed out, that spike that we saw. And it also just this increased recognition of the morbidity and mortality associated with these, with the RSV infection in older adults, especially those with risk factors. So we're just sort of becoming aware of how significant this is. And the RSV vaccine just came out, a couple years ago. So we didn't really have good treat options to vaccinate this population. And so now that we have these tools available, we have something to do about it and a way to prevent this significant disease burden. I don't know, Joe or Amanda, did you have any other thoughts about that?
Yeah, and I think too, someone brought up in the chat too that, in the past we didn't test adults. So like, how's that biasing the numbers? And it's some fair points that like there has been definitely a lot of changes in how testing's happening. I know even within my institution, we only recently kind of routinely started testing adults, mostly in the hospital setting or emergency department setting, but certainly not in the outpatient setting in a routine manner. Do you have anything else, Amanda? Yeah.
I think you covered it all.
Yeah. I think some of this plays also into the next question I had to do is what kind of data or studies are out there that link RSV, COVID-19, and cardiac events, whether cardiac arrest, heart attacks, particularly in certain groups. And there is limited data, particularly if you like isolate to 40 to 60-year-olds or just to adult males. But there is, I did see, and I'll put a link in the chat. There is a interesting study published in the JAMA network about cardiovascular events in hospitalized adults, and that that showed increased odds of cardiovascular events during a hospitalization. And this data came from Singapore, so whether it perfectly translates to the U.S. healthcare system may be hard to say, but it certainly shows an association between RSV and events, more so that was more pronounced due to RSV than if patients had COVID-19 and had boosters for COVID-19. So definitely provocative. I think that's an area where hopefully there'll be a lot more data on. Again, I think some of this is also related to the fact that a lot of our epidemiological data is limited by who's actually being tested for RSV, and without doing extensive testing for it, it's sometimes hard to really tease out the epidemiology of what's happening.
Mm-hmm. Yeah, I think that's nicely put, and it's complicated, right? But we do know that especially these patients with chronic heart disease, they get, and we've known this with influenza for a long time, but it also seems like it's panning out with RSV. So they get a bad RSV infection. It ends up in the hospital and then they have a cardiac event. And so we really think that it's the RSV that's sort of exacerbating their chronic cardiac condition that really is putting them at risk for these MIs. So if there's things that we can do, especially in these high-risk populations, to reduce that risk of the MI, that's kind of where these recommendations come from.
We also have a question about copies of the slides. We will be posting this webinar on the AHA web for people to access later on, and so there will be access to it coming up. So stay tuned. And then we have a question on: is there any data that a second dose of RSV vaccine should be given after the age of 75 if patients are given a vaccine, their first vaccine between the ages of 60 to 75? Any thoughts on that?
I mean, that's a great question. And I think that that data is coming because, again, these vaccines are so new, right? They're approved in 2023. So we just don't know right now how long the immunity is going to last. Right now, it seems to last for up to 2 years because that's all the data we have. So I'm hopeful that we'll see that come out in the next few years. We'll see whether or not a second dose is needed.
And somebody asked a question about this. Is it required annually? Is it recommended right now? And the answer is no. So just the one-time shot at 75 or 60 to 75. And as far as we know right now with the recommendations, they're done for life, but likely to change. Hopefully we'll have that data soon. I get frustrated when the guidelines change, but it's sort of, we just have to roll with the punches. So.
Yeah, it seems likely that there'll have to be some kind of booster dose, at some point. If you get at age 60, it's unlikely to last till you're 80, but more to come on that. Okay, next question has to do, is there a link between RSV infections in long-term care facilities and the caregivers providing their care? So is there, I think, I guess the way I read this is, are the potential interplay between caregivers and RSV infections in these facilities. And I suppose we saw this a little bit with, certainly when COVID was during the pandemic, concerns about intertransmission and whatnot. Any thoughts from the panel?
I think that's a great question and a great point. I mean, there's a big push among healthcare providers to be vaccinated against respiratory infections that we can pass on to our clients and patients. But as of right now, there's not a recommendation for healthcare providers to be vaccinated against RSV if they don't meet those criteria that we mentioned. Once again, maybe that'll change, maybe it should change. But as far as I know, there's no data about that and no recommendation out right now.
And I will add, somewhat related, and an area where there is some data on is in terms of kind of generational homes. So grandparents living with their grandchildren, there is, certainly transmission and higher risk of grandparents getting RSV from their little grandbabies in these intergenerational homes. So something to consider as you're talking to your patients and understanding their living environment. And discussing with them about the need for vaccine.
That's usually how I sell it to my patients over 75. If they're around grandkids, then they're most likely going to be exposed to RSV at some point. And so that's usually what motivates them to get the vaccine.
Yeah. Next, we have a question about if co-administering the vaccine, is there any recommendation to give in a different IM site, left and right arm? What do you all think?
So that's a good question. So in general, when co-administering vaccines, it is recommended to give them in different sites, but it's not necessarily has to be a different arm. It just has to be separated by at least 1 inch. So it could be in the same arm if your arm is big enough that you can separate by at least 1 inch. And so that I don't know that. Do you guys have any other thoughts on that?
Well, just depends on the arm then, I guess,
Yeah.
if they have enough area.
Exactly. Just having memories of, holding down my little kids and getting like 10 vaccines in the same thigh. But
Oh yeah, I mean, like with the kids, they just put them all in one leg. So yeah.
maybe you could tackle this, Amanda. Someone asked just to kind of reiterate, what information or data there is on side effects of the RSV to older adults of the RSV vaccine.
So the CDC has it nicely concised in their recommendations what those side effects are. I'm sorry, it's not RSV. So those of RSV or the vaccine. I'm sorry. The question.
Just side effects of the RSV vaccine in older adults.
Right. So they're very similar. So these vaccines really from the recommendations have been given to older adults. And so the information we have about side effects are all coming from that patient population as well. And so all of the reported adverse events from these trials that they've been doing have been coming from that patient population for the headache and the injection site, muscle weakness and fatigue. And then that small risk of Guillain-Barré syndrome with those protein antigens. We may see that, with the post-marketing surveillance with the mRNA vaccine, since it was just newly approved. Sometimes you see more side effects come out after you've had it on the market and it's had a season to be given in more and higher quantities. You start to see other side effects come out. But as of now, those are what we have is from those clinical trials they've done and these first 2 years of administering those protein antigen vaccines.
And I would say just my clinical experience is that patients tolerate it pretty well. I've written a lot of prescriptions for these, and my patients would definitely let me know if they felt like there were major side effects, and I haven't heard that from my patients. So I feel pretty comfortable recommending it.
Thanks. There's also a question about whether there's a generic RSV vaccine, and fortunately, currently, there's not. These are all very new vaccines, and it may be quite some time before we see a generic formulation. We also have a question on, is there resources on the pathophysiological components with cardiovascular and respiratory disease? Any comments from the panel? Now, I'll mention that we will, when we share this webinar online, there will be references on most of the slides. I will say though, a lot of the references are more epidemiological, and we didn't go deep into the pathophysiology of why exactly the RSV virus causes some of these patterns of worsening cardiovascular respiratory exacerbations. Some of it is often thought to be due to the inflammatory response, and we see with other acute illnesses, inflammation can often worsen, heart failure or worsen asthma, etc. But unfortunately, we didn't do a deep dive into some of the data behind that within this presentation. And then one of the last questions we have is, with the current state of flux in the CDC, can we continue to rely on their recommendations, and how should we consider that in the future? It's certainly a great question. Any comments?
That's tricky. I still trust the CDC. I think it's a legitimate question, and we should all be skeptical about our sources, but it's still a reputable organization, and the scientists putting out these recommendations, I think, are still doing a good job. And so I'm still trusting them. I know that's a harder sell with some of our patients, really on both sides of the spectrum, but it's kind of the best that we have, and so I'm still relying on them.
Yeah, and I suspect a lot of our payers, at least for the time being, are going to largely go by the CDC recommendations for manage, insurers' pain. But a lot more to come in this area. It's certainly an important question we're all dealing with. Well, with that, we're coming to the end of the hour, and just want to thank everyone for joining us, and appreciate all the great questions, and wish you all best wishes. And please join us on July 14th for our next edition. Thanks.